Does a payer prefer a patient to be seen at a wound care center or an ER or a DPO or some sort of outpatient setting? Where is the sweet spot today for a payer?
I would say there isn't any. Do you know of a sweet spot?
No. Again,
Since it's spread out over...
my it depends answer is again
You got a rubber stamp
coming up. It really depends on the payer. It depends on the gatekeeper. If the gatekeeper, let's say, is capitated and understands the dynamics and the importance of this, and knows that if the patient is seen by the right clinician at a wound care center, then the costs will actually be less than they would be if the patient didn't go to that center. Then that patient will likely be referred there. Others may not be as well versed in this topic. They'll flatly refuse things like hyperbaric oxygen as an example because they, quote, don't believe in it as if it's a religion.
And here's an area where the product manufacturers can bring some very interesting technologies to bear in order to leverage the capabilities of what we would call the centers of excellence, like an outpatient wound care center, into the community, where the home health agency can have technologically enhanced capabilities in order to be able to access a center of excellence's protocols for wound management, and then the attendant costs go down.
You know, I had one other thing to add, and that's the continuum of care. I think what tends to happen is, particularly if a patient is hospitalized with a serious problem, let's say an infection or even sepsis, and then is discharged, very often they fall into a black hole somewhere. They're not really seen by a specialist.
I fixed their sepsis.
That's a great point,
right.
Come on.
Exactly.
Well,
and that's a big
point,
problem.
Because a lot of times, many stage 4 patients that are the costliest comparatively, from an acute perspective, by definition, can't get to an outpatient wound care center with enough reliability to be able to establish an appropriate treatment protocol.
But their Pseudomonas went away.
Exactly.
It's gone. We
but
fixed
the hole
him.
didn't.
But the hole through which it entered remains.
Correct. Right. So we just don't treat the hole, we treat the whole patient.
Oh, I'm liking that. Again, if there is a managed care approach to this, in which a managed care organization standardized care. First of all, I can't believe I'm speaking well of this because most doctors beat managed care organizations over the head. Does that make sense to you that this managed care organization is going to mandate that a patient who had a hole and had sepsis gets the hole fixed or attended to as well? Does that make sense?
It certainly makes sense. Whether or not it would happen, from what I know about how most managed care organizations think and function, I'm not sure, but it certainly makes sense.
By the way, I'd like to point out he did say that managed care organizations do think.
Well, you know, to that point, maybe they haven't looked at it correctly because of the conditions that can beset Medicare beneficiaries. We talked earlier about how a chronic wound is up in the top 5 for cost ratio reimbursement. In other words, they get a higher bump in their risk adjustment. If it's one of the only conditions that can be healed in a reasonable period of time. So in other words, if let's say an HCC is in the area of ventilator dependency, which is really close to where a chronic wound is. Think about that. Ventilator dependency, according to Medicare, costs about as much as a chronic wound.
That's huge.
Okay? Can you heal, or can you, and otherwise, what are the percentage of patients that can be healed on ventilator dependency versus those that can be healed appropriately through standardization of treatment protocol and all of the other advantages that we can consolidate? All the tools are there. And if they're consolidated, you heal a wound in a 90-day period of time, there's an incentive for that managed care company to be able to cut that cost. And it's one of the few areas that can quantifiably be cut.
The second part of that equation is to prevent the rate of recidivism as well, because once those wounds heal, if the patient is not compliant or concordant, as we like to call it now, or their disease...
Is that really the PC phrase for compliant? Concordant?
Yes.
Okay, just wanted to know.
Well, it's an interesting point because I based my entire career on this. One of the sobering things that I heard from a medical director was, you know, we always tried to close the wound, close the wound, close the wound. So I was on the phone with one of the managed care medical directors and I said, you know, doc, I wasn't able to completely bring this wound to closure. He said, Mike, this patient hasn't gone, since you've been treating this patient according to the model that I had set up, this patient has not been readmitted to the hospital, okay, in an entire year, okay? So I don't care if you ever heal that patient. That patient has been stabilized, they haven't had an infection, their quality of life has improved, and they haven't been serially readmitted to the hospital. So that is a positive outcome. That patient may never
for
heal.
them,
The
for the
patient may
clinic.
never heal. We've seen those, where they close to 90%. However, if we as physicians can keep them in a stabilized state where that wound does not present itself with other life-threatening comorbidities, I would think from a quality of life perspective, the patient is doing better, the entire system does better.
And I think, too, having a realistic expectation of whether or not that will occur, those individuals who really understand wound management as a profession can kind of gauge whether or not this wound has the likelihood of healing or not, and whether or not we can stabilize it.
There is a subtext to your story, right? Which is you paid attention to the wound. That is to say, whether or not that wound closed, that patient got seen on a regular basis and got attended to, and it got cleaned and infected material got removed.
Coordinated care.
Coordinated care.
It
which
was
is what I
treated like a chronic condition. There were case managers at the health plans that were looking at what we were doing. We gave them access to electronic medical records so everyone on the treatment team could see what's happening with that patient. So that if an order came in for a low air loss mattress or some other modality, there wouldn't be a delay, an artificial delay in treating that patient.
So that continuum of care versus what we commonly refer to as siloed care.
Right.
Where individuals are coming in, doing what they do, no communication, they're leaving, and so be it. And call me when you need me again, which normally will be the case if,
Thank you
in
for the
fact,
opportunity
that
to
occurs.
assist in the care.
That's
It's
correct.
fascinating.
That's correct. That's correct. So the continuum of care is extraordinarily important.
Avoid
and
hypoxia and hypotension is usually in that note too, right?
That's correct.
But of course, the major hang up in this coordination of care is the transmission of the right trigger, which is the claims data. So unfortunately, managed care has the same issue that Medicare does in recognizing what's driving the healthcare costs. If the claim doesn't come through primarily as a wound or a wound-related issue, that coordination of care may never be triggered at the health plan
It
level.
might not be triggered, but that's a very good point that you bring up. So what we did was we were assisting the health plans in their data mining by looking at inferences, similarly in the way they capture MRA, but looking at inferences as to what would the most probable inciting diagnosis be for this admission. And then they start getting better granularity on the costs. And some of the health plans that we worked with found out that their PMPM cost for wound management, when the totality was taken into account, from home health to podiatry networks, to surgical networks, to outpatient wound care centers, when that was added up, the PMPM approached cardiology.